Okay, thank you very much indeed for inviting me here today. I know that there's probably quite a varied audience here. So what I'm going to take you through is really my involvement with image guidance systems. And I'm going to discuss some of the areas that we've been working on, some of the developments we've made, some of the catastrophic failures we've made, and a few successes, hopefully. So, augmented reality, I think that was the topic, and of course we need to have a definition if we have a topic, and that means that augmented reality is technology that overlays virtual images and information onto the real world. And if you believe Tim Cook, who's the Apple chief executive, augmented reality will change everything. Now, as you can see, he did meet with our Donald, and I think by his expression they were probably talking about taxation and Apple's avoidance of tax, because he doesn't look very pleased. So, is it going to change everything? What I'd like to do is give my perspective on that, and base that round about some of the developments we've been working on. So the format of the talk is that I'm going to discuss our pathway for the development of an image-guided system for laparoscopic liver surgery. I'm then going to discuss one of the key problems if you're going to develop laparoscopic systems, which is that you can't touch the tissues and it's very difficult to define cancer margins. Then I'm going to go on to discuss briefly some other areas related to pre-malignancy of the pancreas and advanced pancreatic cancers, and some of the areas that we've been working on there that hopefully you will find of interest. And lastly, I'll discuss some of the things we haven't done, but we certainly think that we should be doing. I have no conflicts of interest. So a little bit of background to augmented reality, and this is really where we were before we started our development work. The concept was fairly straightforward. From the point of view of what we wanted to achieve, we wanted to take our preoperative three-dimensional imaging and compare it and overlap it with our surgeon's view of operative procedures. And this would be the concept of your surgeons having X-ray vision to view anatomy that's not typically exposed at surgery. So a very simple concept. And before we were involved on liver areas, there's been quite a lot of work in this area, particularly orthopedic systems for image guidance, neurosurgical navigation systems, quite well established, but those are established in areas where the organs and the structures are fixed in place, and that makes a big difference to image guidance systems. There is, as you can see, a big market in image guidance. It's reckoned that the market's about £3 billion per year in image guided systems. And I think clearly we all understand that if we get more information, that's a very important situation. It could lead to increased safety of procedures. It could shorten operating times. It could facilitate the planning of very complex operations. It could be discussed in advance. And it could increase the number of patients who have the benefits of keyhole or minimal access surgery. So we started off with a simple vision. I like simple visions. I'm a surgeon, so everything's quite simple in my view. And the simple vision that we had to begin with was that all patients that require liver surgery will be able to benefit from laparoscopic or keyhole surgery. So from the point of view of the development of a program of research work, it's always very good to make the vision very simple. So we had a simple vision. And could we back up the simple vision? Is there any evidence to support it, that it was important to do laparoscopic surgery? Well, there are exactly the same suggested benefits of laparoscopic liver surgery as for other forms of laparoscopic surgery. And as you know, the evidence from multiple trials is that it's good for patients. Minimal access surgery is less painful, it has fewer complications, faster recovery. And that translates into benefit for the NHS, what we all pay for, reduced hospital stay and reduced complications means less money. And the thing we always miss out is what about societal benefit? We never think about the benefits to society. You put the patient out home and you think that's the end of story, but they've got convalescence, they've got time off work, they've got support of their family, and these are all societal benefits of better surgery. And this quote at the bottom there is actually from a patient of mine who has worked with us on this program, and he said, well, forget all that. My feeling is that the key driver is that you avoid physical and psychological burden of major open surgery. It has more scars than the one in the abdomen. So what's the background situation to laparoscopic or keyhole liver surgery? About 5% of all procedures in the UK are done keyhole, and our vision is that it would be 100%. We have to ask ourselves, well, why is it only 5%? I think Dr. Shadrawi would say, well, we've just got very poor surgeons. And probably he's got some support for that. Maybe HPB surgeons aren't as good at laparoscopic or keyhole surgery. Or maybe it's because the organ that we're operating on is complicated. There's a little diagram down here, and just shows what we have to deal with from the point of view of plumbing, all this complex anatomy of blood vessels going in and out of the liver, damage to which can make the big difference between excellent surgery and a fatality in surgery. So it's maybe that it's just too complex an organ for laparoscopic surgery, or it may be coming back to this issue about palpation. Certainly in open surgery, palpation of tumours and controlling tumours and blood vessels is done in large part by palpation and intraoperative ultrasound. And I think that there's probably not been the uptake from HPB surgery because surgeons are concerned they're going to do patient harm. So way back in the beginning of 2000s, we put together a big team to take on this question of whether or not we could transform surgery, laparoscopic surgery, utilising image guidance. And there were no systems of image guidance for the liver, and there are still no systems for image guidance in the liver. So we started to develop one, and we put together a large research team, mainly computer engineers, a few clinicians, and a lot of support individuals. And the Wellcome Trust appreciated that this was quite important. They thought, yes, that is a very good justification for development, and they supported us. And back in 2012, we got a grant for over £2 million to develop this system. And we employed a whole series of software engineers to work with us in this problem. Modestly, we called it the Smart Liver Surgery System. I'm sure that kept most people amused. And the concept that we had was that we would have individualized patient care, and we would take the three-dimensional model of their surgery. And for those of you that don't know that much about the liver, this is the liver up here. There's a very large tumour at the back of the right side of the liver. And this is the model of, I think it probably is, of that patient, where we then have a segmented three-dimensional structure that's produced of an individual patient's liver. And we can do that with automatic segmented systems in about 48 hours. So if you have your patient that comes along and has a fine-cut CT, we can then produce a three-dimensional model of that individual patient's tumour in 48 hours. And then we take that model, and in theatre we track the laparoscope. This is a tracking device that's used in theatre, and we track the laparoscope, and we can then produce an onlay. So this is the picture that we see at the time of laparoscopy or laparoscopic surgery, with an onlay of the blood vessels. So that's taking the preoperative three-dimensional image and onlaying it on the liver. And it looks as if we've already achieved it, but I can assure you we haven't, and I'm going to run through with you some of the steps that have been involved with this process. So what are the challenges we had? Well, it sounds very simple, but there's very, very complex calibration when you have to take a system which is moving and constantly focusing and unfocusing on the liver, and to get that calibrated and to have the system following the moving structures. So calibration and tracking was a very major problem. Then we had the problem of bringing very large complex equipment into theatre where it's not its normal habitat. And we had the problem of engineering a reliable system, because the engineers just love to sit and program all day, but you say to them, well, how accurate is that and how reliable is it? And they go, well, we don't know. So there was a big issue about not only producing the system and the software, but about the reliability. So this was one of the systems. We started working with phantom models. So this was a phantom model of a liver that we imported from the US, because there seemed to be one person who mainly spends his time showing blood and guts for movies in the States, who manufactures organs. Of course, not real organs, but manufactures organs as close to reality as possible. So we had one of the phantoms imported from the States, and we did a lot of calibration work and set up all the calibration initially in the lab. And the way the calibration devices were done was that we calibrated the scope using a system of hatching, and we could get the calibration done by moving the hatching, which is a fixed angulated source for deformation and for calibration, and we used that along with other methodologies to set up the calibration of the system so that we knew what we were looking at and that it was representing true life. We worked on many other systems for calibrating the scope. This was one of the surface reconstructions. So the concept here is that we would calibrate by using a whole matrix of dots on the liver surface, and then we would then track where the dots were and what was movement and non-movement and what was angulated and non-angulated. And we could then use that dot matrix to put the three-dimensional model in the right place. So at the end of that, which sounds quite straightforward, but that was 3 years of work, at the end of that we had constructed a system that was accurate to within 3 millimeters for all major structures, which sounds pretty good. So we always have to ask ourselves, well, how accurate do you need a system for? If you're dividing the liver, do you need to know whether or not you're within 3 millimeters of a major structure, or should it be 5 millimeters, or should it be 10 millimeters? Nobody knows. So one of the questions is, we didn't know how accurate we had to make the system. So we thought 3 millimeters was good, and we got it reproducible in 3 millimeters, and then we decided that we would move on to demonstrating whether or not we could have similar reproducibility in an animal model. Now obviously when you go for an animal model, you increase the complexity, there's lots of variables, and there's no adequate animal model. So what we wanted to do was to have an animal model that had a tumour that we could image and that was big enough for it to represent what we would find in patients. So we decided that we would set up a pig model. We would produce artificial tumours by ablating the liver, and then we'd CT the pig, and then we would produce a 3D model of the pig's liver with the artificial tumours, and then we would carry out laparoscopic liver surgery on those pigs that had the tumours. And this is the setup. This was the size of pig we were using. We were ultrasounding to isolate the liver and to identify the place to produce the focal tumour nodules. This was it, all under aseptic conditions, and we were here using a microwave probe to produce artificial tumours in the pig model. And then if you think it's very complex, how would you manage to get a CT scan of a pig? It's an absolute disaster, I can tell you. You have no idea how complicated it is. The scanner was a human-grade scanner that was in a van, and the van had to be parked, I won't tell you where, but it had to be parked at the side of a hospital. Then we had to have a canopy that went all the way from the car park in the van to the centre of the hospital, so that under no circumstances could any aspect of this procedure be visualised. And every time we did an operation in the pig, it cost £15,000. So, not surprisingly, we were under huge amounts of pressure to get it right, to get the right system, to minimise animal utilisation, and to get high quality data. So here's a little piggy having a CT scan. This is the pig's liver, and this is, if you look up here, you'll see the ablation zones we formed. We then produced a three-dimensional model of the pig's liver, and then we subsequently carried out laparoscopic surgery on the pig. And you probably wouldn't be able to tell, but these are the tumours that we'd produced in the liver. And here's our laparoscopic probe, and here we're visualising the liver, and we're producing an onlay of the vessels. So this is the pig's liver, this is the outline of the liver, and these are the pig's blood vessels from the three-dimensional model overlapped onto the liver, and these are the tumour nodules we've produced. So that all looked good. It was quite successful. We could demonstrate that we could produce a model of the pig, that we could carry out laparoscopic procedures and evaluate these pseudo-tumours. The only problem we had was that the pigs were ventilated to keep them alive, and we divide the liver, the structures change, so deformability was a huge problem. And despite a lot of work on this, the error we got in the pig model was actually far higher than in the phantom model. Maybe that's what you would expect, 10 millimeters, but that was of concern for us. However, after a long discussion with lots of liver experts who said, well, it doesn't matter if it's 10 as long as it's consistent. What we want to know is consistently, will that be the error? What people didn't want to do was have variability in the error. So we decided that after that feedback from some of our liver surgeons that we would go ahead and develop a clinical system. And obviously for safety purposes, we didn't go straight to using the system. We developed the system in patients who consented to have development work, but we were not using the system. And that was a very, very careful ethical issue, so that we weren't putting any patients in harm, but we were allowing important development steps to the system. So we consented 20 patients who were involved with the study. This was the setup in theatre, producing the three-dimensional model, and as you can see here, the individualized model allowed us to overlay the structures and the tumours on the liver at the time. So you can see here the model of an overlay. This is the liver, and you can see the vessels, the artery and the portal vein being visualized. So that was another 2 years of work, and at the end of that we had a system that we felt was safe for use clinically, but we hadn't used it clinically. We just had evaluated it clinically. We hadn't used it to change any patient's treatment. So we then decided that we would have to go for a further development stage. We had all this list of technical achievements, so this was a long program of work, most of it completely new, and was published mainly in the medical engineering literature. So we then went to another funding body, NIHR, who tends to take on more translational aspects, and we asked them, we said, look, this is the data we've got, we would like to do some further clinical evaluation and work on resolving some of the outstanding issues. And because it was translational, we had our patient representative who worked with us on the pitch for the funding, and they were very pleasingly, they supported our project with another funding for £1.5 million to take this towards clinical development. So we had worked through basic research, we had worked through early clinical evaluation, now we wanted to evaluate it in full clinical practice. And these were the challenges and what we wanted to achieve over the clinical study. We wanted to be better at calibrating the system, we wanted it to be quicker and more accurate. We wanted to have additional planning, so we wanted not only to overlap the three-dimensional model for an individualized patient over the liver, we wanted to be able to work out the volumes of different parts of the liver, so as the operation was going ahead, we could have further surgical planning on how much liver we were going to leave behind, what would be the volume of the bits that we removed. And the importance of that is that often we do have to replan our operative procedure as you go through the steps of the surgery. And we wanted to look at other methods of improving the registration accuracy, because we felt that the registration accuracy was below what we would ideally like. So the first thing we wanted to do was to get consent so that we could actually look at the information in real time. So we achieved that, and we've now got consent to actually do the procedures at the time and overlay the information. What we don't yet have is the ability to use the system for changing clinical practice. So we can overlay it, which we weren't allowed to do before, but we're not going to be able to use it to modify the surgical procedure. So we've been working on tracking, and the tracking has also produced some interesting research outputs. We've been engaging with the public, because with such a lot of public money being funded, there's a big interest in how we relay this information to members of the public, how we justify the huge cost that's involved in these developments. So we have to bring people along with us, and this was the research team trying to convince people that they were doing a good job. So that's where we've got to. So we've actually developed a system which is currently being evaluated as we speak on a almost weekly basis. What else have we been doing? And I'd like to just focus, 5-10 minutes? Focus in the next 5 or 10 minutes on some other areas that you might find of interest that doesn't relate to the development of this system, but which is in some ways related, and I'll explain the relationship. So one of the first things that one of the things we've been looking at right from the beginning was, okay, we can modify laparoscopic liver surgery, but what about this problem with not being able to feel the tumours? And there is no system out there that allows you to get information on where your tumour is within the liver on laparoscopic surgery, other than laparoscopic ultrasound, which I think most of us would consider is not a real-time tool for laparoscopic liver work. So we've been working on photoacoustic imaging, which has it's a light-based imaging. It's based on a photoacoustic probe, which uses ultrasound to generate high-resolution three-dimensional images. And the importance of this technique is that most of the light-guided systems that you might use for determining what tissue was only work on the surface. So the thing that's absolutely fundamental and is absolutely new about photoacoustic imaging is that we will be able to tell what's down inside the liver, so it penetrates several centimetres. So it's never been done in the liver. In fact, it's really not very much been published on it at all. But we now are developing a system for using photoacoustic imaging on the liver. This is the setup that we will have our smart image-guided surgery system. We're going to correlate that with the photoacoustic probe so that we know in 3 dimensions where the tumours are, and the photoacoustic imaging will give us the margins of resectability at the time. So that's a completely novel bit of work. It's just been funded and supported by CR UK. So those are the 2 big developments we've got on laparoscopic liver surgery: a new system for evaluation, a new system for tracking margins to ensure that we completely remove the tumours. What else could you do? Well, there's applications for the same system in other solid organs. And obviously robotics, as you know, is ideally suited to this kind of system, which involves large volumes of data interpretation in real time. So lastly, I'm going to discuss a little bit about what other areas we've been working in, and I'm a liver and pancreas surgeon, so the other things that interest me enormously is the 2 big problems in pancreatic cancer. One is that by the time we diagnose it, the chance of curing it is small. So early diagnosis is absolutely key for us to improve outcomes in pancreatic cancer. And then the other area is to realize the limitations of pancreatic surgery. Pancreatic surgery is probably of value to about 10% of patients presenting with pancreatic cancer. And the big group of patients that have presented with pancreatic cancer have locally advanced or metastatic disease, about 70% of all patients. And in those patients, surgery probably doesn't have much of a role. So I was interested in us developing a system for early diagnosis and an alternative system for palliative treatment. So what about early diagnosis? I'm sure most of you know that pancreatic cysts can sometimes become cancerous, and pancreatic cysts are incredibly common. 1 in 30 of us in this room will have a cyst in the pancreas. Unfortunately, most of them are benign. But there is a significant group called these IPMNs, which are precancerous. And we don't know exactly how many pancreatic cancers have arisen from these precancerous lesions, but probably a significant percentage of them. So if we were able to treat these precancerous lesions, we would probably reduce the number of patients presenting with advanced pancreatic cancers, which has a fairly poor outcome. So that all sounds good, but what's the problem? Well, the problem is that we use certain criteria to decide on which patients with pancreatic cystic tumours should have surgery. And even if it fits to those criteria and we operate, only a quarter of the patients that have their tumours removed have got cancer. So there is a bit of a problem there, because pancreatic surgery has high risk, and the majority of patients that we're removing their tumours have benign disease. So we were quite interested in trying to address the problem of avoiding surgery unless it was necessary. And what we have, and I'll be interested in Ray's view, is that we developed a system for image guidance to facilitate endoscopic pancreatic cyst sampling. And the concept here is that we would track the end of the endoscope so that we could then correlate where the endoscope is in relationship to the cyst. And we would use a three-dimensional model, just as we did with the liver, to demonstrate where the pancreatic cyst was. And we would therefore have a guidance system to say, Ray, you need to go over here and you need to biopsy this bit of the cyst, because this is the bit of the cyst where we think the cancer is. So that's a project that has been running. It's been running for the last 2 years. There has been some published outputs, but it is not yet got towards clinical practice. So a preclinical, but I think interesting development. So the last thing I want to mention is going to the opposite spectrum, not of the early stage disease, but actually the advanced disease. And as I mentioned earlier, if you look at patients with pancreatic cancer, 50% of patients have locally advanced pancreatic cancer. That means pancreatic cancer that is very unlikely to be cured by surgery. It's involving local structures or local blood vessels. And the very interesting treatment that's now been introduced for those patients is called IRE therapy or nanoknife therapy. And if you look at the data on nanoknife, it's extremely impressive. The median survival for an unresected pancreatic cancer is probably about 12 months. And if you look at the cumulative data on nanoknife, the survival is over 2.5 years, about 30 months. So there seems to be an enormous benefit to this treatment. It seems to be a fantastic treatment, a transformational treatment for patients with pancreatic cancer. It does have some limitations. You've got to put the probes into the pancreas, which is not easy, and you can cause local tissue damage, pancreatitis or vascular injury. So we were interested in this technique. It seemed to be fantastically good technique. We wanted to see two things. One is that the data was all based on comparative cohort studies. It wasn't evidence-based data. There was no randomized controlled trials. And one of the problems was that perhaps it was being used for patients that had early stage cancers or earlier stage cancers where people were trying to remove the cancer but did the treatment when it wasn't resectable, and perhaps that was skewing the data. But more importantly, there was no system out there for actually getting the treatment to the right place, for actually ensuring that the needle electrodes were in the right part of the tumour. And clearly the electrode placement and the treatment that emanates from the electrodes is just a mathematical stroke biological problem, which therefore can be resolved. So we've been doing two things related to these local advanced pancreatic cancer. First of all, just this month we've got news that we will be funded to do a multi-centre trial in the UK, and it's the first global trial, randomised trial of IRE treatment. We're going to do it only in patients that have had first-line chemotherapy, and after the chemotherapy the pancreas tumour is still unresectable but amenable to this treatment, and they'll be randomised to having this treatment or ongoing palliative treatment. And on the question of the probe placement, we've had an engineering group that have been working on that, again based on the concept of having a model of the tumour with guidance. So here a model of the pancreatic tumour in 3 dimensions, which can then be used to guide the electrode placement. So we've been working on that. We've been working on model systems, and we do have some very early data showing that you can actually use image guidance to facilitate probe placement. So those are the main areas that we've been working on. What else do I think might be interesting? I'll tell you where we're going with some of these things. We're planning a smart surgery system for the pancreas. This meeting today, I think, has gone into training issues, and I think that there is a training opportunity not only in rehearsing major surgical procedures, but in training for all procedures, because the smart surgery system of producing a 3-dimensional model could be integrated with virtual reality training, so that you could train the day before you do an operation on that patient's imaging, on that patient's tumour, on that patient's gallstones, on that patient's biliary tract. So we're doing some work on trying to get that concept in place and funded. And then maybe back to my pet love about the biliary tract. What about cholangioscopy? Cholangioscopy is fantastic. You can go up the bile ducts with a tiny, tiny scope and find tumours, but then your hepatobiliary endoscopist come back and says, yeah, it's up the bile duct. And I'll go, well, which bile duct? And they'll go, I've no idea. So what we want to do in cholangioscopy is for us to produce a 3-dimensional model of the liver, which we can then track the cholangioscope up the bile ducts, and we will know not only where the abnormal tissue is, but we'll be able to see that in the 3-dimensional model, and we'll be able to know exactly what kind of surgical procedure requires to be done. So that's the main areas that we're working on. So just to conclude, I think that hopefully I've shown you some of the things that we've been working on that you might find of interest, and that you might find that you could perhaps develop in your own speciality. I think the importance is that there are so many technologies that are developing that we need to keep abreast of those technologies and what's useful and not. We need to have a pathway in the UK between concept and clinical trials and evaluation, and that's just being developed now. Both the Wellcome Trust and NIHR are working on those pathways. And I think that before we get engaged in the very complex technology, we should come back to say, well, what is the benefit for the patient? And if we can't identify clear patient benefit, we shouldn't throw in complex technology. And I think the quote that I'd like to leave you with is Abraham Lincoln: the best way to predict the future is to create it, because I think this is what we're doing. We're creating future options. I should say that we've been enormously supported by the Wellcome Trust, just funding our clinical engineering group, the Vice Centre, which you'd be all most welcome to visit. And thanks very much to the big team, both engineering and clinical, that have been involved with this work. Thank you.